Well, first of all, there's so many patients that fall into this category because women are living long past cancer, right?
Absolutely.
Cancer survivorship is there, and we're thrilled about it.
Absolutely.
So women are living 1/3 of their lives in menopause. So we do address it. We talk about hormones, but we really talk about women's health in general.
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancer Inc. Show. If you're a woman of a certain age, you may be familiar with the symptoms, that surge of heat, whether it starts at the top of your head or comes straight out of your chest, a lot of sweating, mood swings, maybe trouble sleeping at night. That's right, I'm talking about the change of life we know as menopause. You may wonder, why are we talking about menopause on a podcast about cancer? To answer that question, we have Dr. Constance Dabezies, a board-certified OBGYN who joined USA Health in 2022. Dr. Dabezies is one of only a few providers in Alabama to hold the Certified Menopause Practitioner designation from the Menopause Society. She is the perfect person to help us navigate the connection between cancer and menopause. Dr. Dabezies, welcome to the show.
Thank you so much. We're thrilled to be here.
So tell us how you got from being a regular OBGYN to being specializing in menopause.
Well, I will tell you a little bit more about that. I'm a board-certified OBGYN. I practiced for many years in private practice and public health and also clinical research, bringing drugs to market. And I realized that there is an area that we're not addressing in women's health, and that's called midlife health. During midlife, women are at risk for cancer or at risk for heart disease. We're the perfect people to help them navigate through this world.
Absolutely. And we talk all the time about risk for cancer. And just to clear the air, is there a risk for cancer associated with being in menopause, or is it just age?
So there is not a risk associated just with being at menopause. This is where we are. You're hit this certain place in your life, and this is when cancer risks go up.
Right.
And we'll chat a little bit more about the cancers that women are at risk for, as you know, breast cancer, endometrial cancer, colon cancer, lung cancer.
Absolutely. And women are so used to coming to their OBGYN for their breast and cervical cancer screenings. Do you feel like OBGYNs are the people to do the other screenings?
I don't think we have to do the screenings. I think we need to get them set up for their screenings. And that's the first thing we talk about when you come to my clinic is cancer screening before we even talk about menopause.
I love it. You know I love it. That's my heart. So how often do you encounter patients dealing with menopause and cancer?
Well, this is something that I see all the time, mostly because when they do get diagnosed with cancer, which is at an older age, they're in menopause, they're about to enter menopause. And quite frankly, their treatment very often can induce menopause.
Tell me a little bit more about that. We're talking not just about people on hormone blockers, people who are getting chemotherapy around the time when they would otherwise be going through menopause.
Absolutely. This is a time where they're being treated, and maybe they were treated surgically, and they've undergone a hysterectomy and a bilateral salpingo-oophorectomy, and they're in surgically induced menopause. And often it's just due to radiation chemotherapy.
Got it. So those treatments inducing menopause early, which we know can happen.
Absolutely. There are also times where we induce a premature ovarian insufficiency, but not a complete menopause. And so it's important for patients to come in so we can counsel them about birth control during this time, as well as their future fertility.
Very interesting. And we are planning another episode to talk just about fertility in cancer treatment. So we're going to leave the fertile women behind, unfortunately, and move into the connection between cancer treatment and menopause. Can you explain how cancer treatment can affect the experience of menopause?
Well, when women go through menopause, there's a slow transition, and it's a normal part of aging, right? The atresia of the ovarian follicles. We know that we're born with about 20 weeks gestation. We have about 7 million follicles. By birth, we have about 5 million. By puberty, about 500,000. And by the time you hit menopause, you only have 500 left. So we know that this is a natural aging event, and our body will accommodate it as we go. But if you go through cancer treatment or surgical menopause, you're going to have an abrupt decline in estrogen. And this accelerates heart disease, osteoporosis, many comorbid events occur during this time.
So talk to us about the most common symptoms and challenges when a woman has either natural or treatment-induced menopause?
Well, estrogen receptors are found all over the body. So as you can imagine, when women go through surgical or natural menopause, they have a loss of estrogen throughout their body. So the symptoms are felt all over the body. We know that the brain is full of estrogen receptors, and we start seeing cognitive decline. We start seeing mood disorders, anxiety, depression, especially if patients had issues with this in the past. Perfect example of that is when a woman goes through postpartum depression, she loses estrogen, and this is primarily the cause. The same thing's occurring when a woman goes to menopause. It's interesting, though, because we know that not every woman will experience this. Every woman will experience a drop in estrogen after she has a baby, as well as a drop in estrogen after she goes to menopause. But it's our sensitivities to our hormones that change how the clinical picture.
So not every woman has to have the severe symptoms that we hear about.
No, there are a multitude of symptoms affecting every organ system. The most severe are going to be the vasomotor symptoms, the genitourinary syndrome of menopause, the cognitive brain fog, as patients will call it, mood disorders, but it can be as simple as changes in their hair, their skin.
Let's walk through some of those. Are they the same for cancer survivors?
They're actually can be made worse for cancer survivors because they've also been through treatments which may have given them long-term side effects such as neuropathies, other issues that have affected their health. They may have had cardiac issues from their chemotherapy.
Okay. So we want to walk through kind of what are our treatment options for women who, let's start with women who don't have a hormone-sensitive cancer, who maybe are in menopause, they are cancer surviving, and whatever menopause symptoms they had, if it was new onset related to chemo, or if it was, something they had before cancer treatment now is more severe. How do you approach that patient?
Well, first of all, there are so many patients that fall into this category because women are living long past cancer, right?
Absolutely.
Cancer survivorship is there, and we're thrilled about it.
Absolutely.
So women are living 1/3 of their lives in menopause. So we do address it. We talk about hormones, but we really talk about women's health in general. Mm-hmm. Hormones is not the only part that we talk about. We talk about cancer screening and then quality of life and what they expect. For patients who have not had an estrogen-sensitive cancer, we have so many options. Our options are safe. We have clinical trials that now show that hormones are safe. We're using different hormones. Not all estrogens and progesterones are created the same.
Absolutely.
Just like all heart medications are not created the same. So we now are able to give bioidenticals, and we feel confident with our treatment plans. And when I say bioidenticals, I don't mean something that is coming from a compounded pharmacy. These are hormones that are FDA approved. They are at your pharmacy. They are covered by insurance in most cases. These are the hormones that are most identical to the hormones your body naturally produced from the corpus luteum and from the ovary when you were in your reproductive years.
So as a woman of 50, I can safely say these are not my mother's hormones.
They are not your mother's hormones. They are not synthetic. They are bioidentical and most like the ones that your body created. And as we know, this whole problem is due to the loss of our hormones.
And so for a woman who is embarking on a hormone journey, a hormone replacement journey, I should say, let's talk about those options. I know we have pills and patches. I know we have creams, and some applied to the skin, some applied to the genital area. Talk to us through some of those options.
So the options are many now. Of course, there are different ways of taking hormones, as you said, transdermal, oral, skin, patches, gels, creams, etc. But I like to make the differentiation between systemic hormone therapy for my patients and localized therapy. And as you know, localized therapy is the use of estrogens in the vaginal and vulvar area that dramatically increase the quality of life for women. And this is something that women can be on for the rest of their lives. Even breast cancer survivors.
I think that's the thing we talk about so much is even people who have hormone-sensitive tumors, so hormone-sensitive cancers, are candidates for genitourinary estrogen use.
They are, and they should be. And they should be on this for the rest of their lives. As you know, so many of the issues that we have as we age, the genitourinary syndrome of menopause, the recurrent UTIs, incontinence, urosepsis, sexual function, a big one, are all related to vaginal estrogen. And it is an easy fix. I have so many ways that I can help them with this. The next thing we talk about is systemic. Are they a good candidate for systemic therapy? Mm-hmm. Now, there are very few contraindications to it. And we do have to do evaluations of their heart, make sure that they are a good candidate.
I was just going to say there are reasons other than cancer that people might not be a good candidate for hormones, like blood clots.
Certainly, if you've had a patient who has a DVT or a pulmonary embolism in the past, they're not going to be a candidate. If they have a family history, that doesn't knock it out, though. The contraindications are going to be a personal history of blood clots, liver disease, breast cancer, personal history of stroke, personal history of heart disease. But these are things that we delve into their family history to evaluate them for.
Right. Excellent. And now talk about some of the challenges for women who do have a hormone-sensitive cancer. What treatment options are available for them?
So for all my patients, whether they've had an estrogen-sensitive cancer or they haven't, we go through the non-hormonal options because there's so many more now. Now, what you want to be careful is that you're following level 1 evidence. You don't want to read something that says this may prevent this may cause this. As you and I know in academic medicine, we want to follow evidence-based medicine. So what we know now is that cognitive behavioral therapy and hypnosis are tremendous in the treatment of menopausal symptoms. We also use what we call neurokinin B antagonists, which are medications that actually block the receptor in the hypothalamus to stop the hot flashes. We use gabapentin, we use oxybutynin, we use antidepressives, we use stellate ganglion block, and of course weight loss. And these are the main areas that we focus on, and there are more coming. Of course, if you're not giving women estrogen, you're not preventing some of the other things, the heart disease that we see, the osteoporosis.
So let's talk about that. I know women, especially cancer survivors, are very concerned about maybe even long-term estrogen blockade and how that might affect their heart or their bones or their mind. How do you counsel these patients?
Well, that is real. So hormone replacement therapy is not currently clinically indicated for the prevention of heart disease or the treatment of osteoporosis. We have 4 clear-cut indications, but we have so many more coming as we do more randomized control studies, and as we pull together our observational studies, we see that there are other effects all over the body. So currently, hormones are indicated for severe vasomotor symptoms, for genitourinary syndrome of menopause, for the prevention, not the treatment of osteoporosis, and for premature menopause. And I'd like to jump in there and talk to you a little bit more about that because women who go through premature menopause or premature ovarian failure, especially under the age of 35, have a 3 times increased risk of a myocardial infarction at an early age.
And we know that there are younger and younger women being diagnosed with, for example, breast cancer, uterine cancer, and others that we are inducing very early menopause.
We are inducing early menopause. There are 2 things I'd like to remind our patients on that. One, in some of these patients, it's going to be reversible. We're inducing menopause, but their ovaries may work later, so we're good. And also that we can safely give them bioidentical hormones. Now, we currently don't give systemic hormone therapy to breast cancer patient survivors. We know that if you have an estrogen-sensitive cancer, there are increased risks. So we do talk to the oncologist, we talk to the patient, and we do shared decision-making on how to treat patients. If you've had a history of ovarian cancer and you're cancer-free and you had an early-stage low-grade cancer, we do give estrogen therapy. Of course, if it's not a serous or a granulosa cell tumor.
Right.
With endometrial cancer, if it's low-grade, early-staged, and it's not a leiomyosarcoma or a sarcoma, we do give estrogen back. At this point, it's a risk-benefit analysis, and we really sit down with the numbers and look at the risk and the benefit and the quality of life. The most important conversation we ever have is the benefit.
Right. And I think about for our very young patients diagnosed with some of the things that you just mentioned, there seems to be, a concern about hormone replacement. And I often need to remind the patients that the doses that we're giving you are lower than what you would naturally have at this point in your life.
Yes, I do talk to them about dosing, and we're very careful with dosing. We start dosing at the lowest dose possible, and we go up as they need it. We also know that the amount they need is the amount that covers their symptoms.
Right.
So many patients come in, they want their levels checked, but our sensitivities are all so different to hormones that we know that you have to listen to the body, the physiological response to the estrogen, rather than dosing and following levels for most hormones, I must say.
Excellent. I'm glad you mentioned the checking levels or not checking levels. So we've talked a lot about the symptoms, but talk to me about, it feels like it's almost a downward spiral. The patients, when I talk to patients about hormones symptoms or menopausal symptoms and mental health, we talk a lot about things like sleep because it does feel like it really impacts your wellness. And similarly, sexual health and sexual function impact your wellness. How do you talk to patients about these symptoms and where to go?
Well, one of the first things they come in complaining of is changes in their memory. Patients will come in and describe a brain fog, and it scares them to death. When you start forgetting the names of people, if you're a surgeon and you're in the operating room, you can't remember the name of the instrument you need. If you're a CEO of a company and you can't remember what you came to talk about, or if you're an OB-GYN and you're on a podcast and you can't remember what you're going to talk about. The memory issues are large, but we do know that in this age group, true dementia is very rare. 80% of people are not going to have dementia. These are going to be associations of loss of estrogen in the brain. The first thing we talk about is cognitive health. Estrogen is not just a hormone for reproductive health. Estrogen receptors are found in the amygdala, the prefrontal cortex, the hippocampus, all areas of verbal, memory, learning, and mood. When we scan the brains of women going through menopause, we see hypodensities in these areas, which are consistent with memory changes, cognitive dysfunction. So we start talking about that because that's usually one of the most frightening to them, along with the other symptoms like vasomotor symptoms, and they want to talk about sexual function. We get through it all. We talk about sexual function because it's multifactorial. It is not just the loss of estrogen. We can treat it with the loss of estrogen with hormones. We know it's a circulatory problem. It's a neurological problem. It's also emotional and behavioral for women. And that is huge.
Yep. And I talk to my patients, and it's an oversimplification, but men need sex to feel well, and women need to feel well to want to have sex.
Absolutely. And many times the husbands come in as well, because I try to explain to them that this is a normal physiological change that we're dealing with. And we can talk through ways of treating it, but we have to hit it from all sides. It is not just a shot of a hormone that's going to make you feel better. And as far as the wellness, patients come in and they want to feel well. And so you have to address this from a multidisciplinary approach, correct? And I always tell them you cannot buy wellness. Wellness is going to be mental, physiological, and spiritual. So when they come in and they say, I tried these things and it didn't make me feel well, we have to start over and discuss what wellness truly is for women.
I love that. It's so true. We could have a whole podcast just on that.
We could, and sleep dysfunction, which of course, if we have sleep dysfunction, we're going to have cognitive decline. We're going to have mood disorders. We're going to have anxiety, depression, and weight gain. So
Absolutely.
All of these variables absolutely influence each other. We pick them apart one by one.
Right. I love that. I love that. And we all need doctors who can help us with all of those at the same time.
Gynecologists are now being trained in menopausal medicine. And this is not just hormone replacement therapy. This is care for women in midlife and for the next trimester of their life, so to speak, the last third of their life.
I love that. It really is so much more holistic than hormones or no hormones. We talked briefly about the topic of fertility and how cancer treatment for young women can affect fertility. Could you talk through options for preserving fertility prior to cancer treatment?
Yes, and I know you're going to have a podcast on this later, so I'll tell you about two things that are quite interesting. One is egg retrieval, stimulation and egg retrieval with cryopreservation for women who may be concerned about fertility issues. And another is fascinating. It's removal of ovarian tissue, cryopreservation of ovarian tissue. When we place ovarian tissue back in women at a later time, we can give their natural hormones back. This is investigational, and it's being done in some clinical research areas.
So fascinating. We will definitely have to revisit that again. What should survivors know about the other tissues? We've talked about brain. We've talked about the hot flashes. We've talked about the vaginal issues. And you've mentioned kind of bones, heart, and other long-term effects of menopause. What treatments are available for women in those areas if maybe they're not candidates for hormone replacement?
So we all know that we're at risk for coronary artery disease, correct? We know that there's a genetic component, there's an environmental component. We know that we can change what we do. We can change how we eat. I talk to women all the time about changing the way we eat. You don't have to diet, you have to change the way you eat. We also know that exercise is important, movement, and we discuss real numbers and real types of exercise. Women at this stage need core, resistance, balance, and strength. We talk real numbers. 150 minutes a week is a start. 300 minutes a week is our goal.
I love that. I need to start thinking about how many I'm doing. It's definitely not 150, but it's a good starting point.
Well, if they would just walk for 1 hour 3 times a week, and we also throw in a weighted vest on occasion, though the studies are controversial on that, it's fun. Feels good.
Yeah. Absolutely. And yes, and I love that you said resistance training, not necessarily lifting weights, but anything that's building muscle.
Building muscle and bone. We know that, like I said, we're at risk for coronary artery disease. We all are. And it's completely accelerated when you go through menopause. You know, we see stiffening of the arteries all over the body. We know that estrogen is a vasodilator. So for people who currently do not have extensive cardiac disease, it's actually going to improve the blood flow to the myocardium. Now, we're super careful in this area because if you do have pre-existing disease, we could create a problem. We could dislodge a clot. We could disrupt a clot. Our new estrogens, or a bioidentical estrogen, is safer in this area. And we know that if we start under the age of 60, that your benefits are far going to outweigh the risks.
And is it still true that for women who've had a hysterectomy, estrogen-only therapy is a little bit safer than combination therapy, or has that been debunked?
That has been debunked. Progesterone is wonderful. It's neuroprotective. It helps us sleep. The old progesterones that we used had more side effects. We're now using micronized progesterone, which has less thrombogenic effects, and it has a calming effect on the nervous system.
So, it helps with sleep. I know a lot of my patients take it for sleep.
It's a sleeping pill. It's a magic pill.
Well, I love to hear that.
The other changes we see as women are going through menopause are osteoporosis and sarcopenia. Now, women will come in and say that their muscle mass has changed, that they have more fatty tissue, that they have visceral fat. We know that osteopenia and sarcopenia walk hand in hand through life. So when you're in your 30s, your muscles were at their best. So were your bones. There's been a decrease over time, but when you lose estrogen at menopause, it's a dramatic decrease. So we see huge changes in the bone architecture. Your bone is building up every day and breaking down every day. And after the loss of estrogen, the breakdown far outweighs the buildup. So we talk about ways that we can prevent this with weight-bearing exercises.
And do you promote vitamin D and calcium ingestion, or do you recommend other ways to build bone or prevent bone loss?
I promote it in their diet. It's the best way to get it to absorb it and the best way to excrete it. You will excrete what you don't eat. Now, if you have a known deficiency, then we add it in.
Got it. I know there are some medications on the market specifically to treat osteoporosis. When do you recommend that women take those medications or consider that?
So, it's an interesting thing. Estrogen helps prevent osteopenia, osteoporosis, but many times people come in and they're already diagnosed with osteoporosis. So we have to look back at whether they're a candidate for medication. If they do have osteoporosis, we have several medications on the market. Some help slow down the breakdown, some increase the buildup. So that's an area where we're spending a lot of time focusing on what's the best method. Currently, we think we need to build the bones back up before we slow down the breakdown. And our medications now are targeted at these two different areas.
That is fascinating. I assume, again, it's a whole another level of science that we might need to spend an episode on.
We could. Currently we order bone density scans over the age of 65, but we really want them prior to that. We want them in the premenopausal range and the postmenopausal range. We don't want to just tell a woman they have osteoporosis. We want to know where their bones are, and we want to treat and prevent.
And so are there at times when you're prescribing those medications for prevention or for someone who's at risk, or is it only once the diagnosis has been made?
Well, currently we prescribe it once a diagnosis has been made, but if the patient's had a fracture, that makes the diagnosis.
Right.
And that's something that most people don't understand. It's not just the T-score.
It's so true and so important. And all the times that I hear women like, oh, when I broke my ankle, broke my wrist, broke my hand, and you wonder, like, hey, you are postmenopausal. Should we be doing more?
Yes, and there's a crazy statistic. 1 in 2 women are going to experience an osteoporotic fracture over the age of 50.
1 in 2?
Yes.
Wow.
And as we know, when we do have a fracture, especially the hip, there's 25% mortality in that first year.
I knew that. It's devastating. So always something we're trying to prevent. So let's circle back. If you could give one piece of advice to women facing a cancer diagnosis and menopause, what would that be?
I would recommend that she visit with her gynecologist. We know that so much of the disease process starts early. We know that so much of it is related to our reproductive health. We know that patients who have complications in their pregnancy are at increased risk later for disease. We talk about gestational diabetes, chronic hypertension in pregnancy, preeclampsia, recurrent miscarriage, PCOS. All of these are signs of something else that's going on. So your gynecologist is going to be your best bet to help you coordinate your care and help you address these issues as you go into menopause.
And then as you move through your diagnosis and treatment and into survivorship, I really loved how you nominate the gynecologist to be your best kind of wellness coach, to look at the whole person, to think about whether or not it's hormonal, whether or not it's bone and muscle, whether or not it's diet, whether or not it's weight, and whether or not it's sleep, mood. You really have hit on all of those.
Well, and I hope we do. The Menopause Society is really are backing this for women's health. This is an organization that really works on evidence-based medicine, data-driven medicine, and is there for women to help them in the workplace, also to help them train the next generation.
Absolutely.
We're going to institute training for our residents and our medical students, which we've already started at USA Health. And we know that only about 20 to 30% of residency programs right now have curriculum based on menopausal medicine.
And I know so many residents prior to you joining us did not feel comfortable with menopausal medicine when they graduated. So this is incredibly helpful.
Well, I'm thrilled to be here and glad that we can help them and train them.
So where can our listeners go to learn more about this?
I would highly recommend the Menopause Society's website, which is menopause.org. You don't have to be a member. You can jump on the website and you can learn so much. There's patient information. There are clinical studies that are provided there that you can read through. And there are certainly guidelines for care. And I would caution patients to follow the guidelines put out by the Menopause Society if you want to follow evidence-based medicine, which is what we need in this area now.
Absolutely. Thank you so much for coming into the studio today, Dr. Dabezies. Always a pleasure to see you, and we so appreciate your expertise.
Thanks for having me here today.
We are so lucky to have had Dr. Dabezies here in the studio today. She is such an expert in this field, and I just loved how she really looks at the whole woman. She's not just talking about hormones or hormone replacement. She's talking about heart health, bone health, cancer risk, your dietary changes, really how to help you live and live well from your head to your toes, including through the end of your life. And I think that that's just so important. I never really thought about the fact that women live a third of their life in menopause, or as she put it, the third trimester. So I will now be thinking of that as I enter into my third trimester. Dr. Dabezies referred all of us to menopause.org, the website for the Menopause Society, and encouraged us as listeners and for myself to follow those evidence-based guidelines. This information is so important for our women cancer survivors, and we so appreciate you listening. We will come back to that fertility conversation as we talked about. And until next time, keep cancering and take care of yourselves. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.